Muchas gracias, Marina.
Thank you very much, Marina. So I'm speechless, to be honest. Now I will give the floor to Eduardo Couchonnal. First of all, thank you very much for the invitation. It's the first time for me. Apologies, because it's the first time I'll be speaking in Spanish with Wilson's disease, but my mother tongue with Wilson's disease is French. But if I make a mistake, please, I'll ask Marina if I make any mistakes. But I'm a pediatrician and pathologist in Lyon, and I'm the responsible of the CRMR Reference Center of Rare Diseases in Lyon. And Marina explained that the diagnosis is difficult because there's not a single test, a conclusive test, rather. And I'll be talking about pediatric population, which is adding sort of difficulties to what we've been explaining, and not only the diagnosis, but also with the treatment and follow-up. And basically, that will be my agenda. I'm not going to be talking about score, but there is not a single conclusive test, so that's why we use a score. Okay, we saw the Kaiser Fleischer ring. We don't really see it that clearly most of the time. Sometimes we have to do a specific test, and this ring is pretty specific if we found it for it to be Wilson disease. We need to think of Wilson's disease of a accumulation of copper. We cannot deplete it. We basically know that the mechanisms of excretion by the liver and so forth. The children are at the beginning of this condition, the course, and we are not going to find this ring all the time. This is a late manifestation. So in children, we don't find this ring, and some publications tell us that in 58 or 38%. So it's relatively rare. It's not so frequent to find that ring. So if we do not identify the ring in a child, it doesn't mean that they are Wilson. And quite the opposite. Another stage of the Leipzig score are the neurological symptoms, and again explaining the continuum of the disease, since it's sort of overloading on the liver. Children will have liver syndromes. This is one of the French cohorts. The first 10 years we see in red the hepatic, and then the green basically siblings and relatives as well, and the diagnosis, and in blue the neurological part, and just a few cases, nearly anecdotal. In our 20s, things start to invest. We have lots of neurological cases, and from the 30s, from the mid-20s, we see that this is more important. The problem here with the pediatric population is that we don't really think too much. I'm not saying that we're better than neurologists, but when there is an alteration in the liver test, we reach the Wilson's disease diagnosis, because it's one of the first things that we think about. That in the neurological cases, there are less cases, and they don't actually think about that. I think it's highly complex because there is a combination with the neuropsychiatric syndromes, sometimes depression. I know many cases in France, and I'm sure that you'll have cases that people undergoing psychiatrist treatment and so forth, and maybe someone started to think, or maybe there was another clinical sign or manifestation, somebody came up with the idea that it could be a Wilson patient, and they did some further tests. But there is a delay in the diagnosis, and this can change from one country to the next. When we find this altered test, we get to the diagnosis. Sometimes the patients can go over a period of 2 years before they are truly diagnosed, and sometimes with children this is even worse. This is what Marina mentioned, the urinary copper. We usually expect that this is increased, but since the children start to accumulate the copper, when we start with the score, the small children with family screening, or maybe they've gone to ER and some tests were being done and there were no further symptoms, basically the urinary copper is standard or not so high. The value tends, the threshold tends to be 100 micrograms, and it's been recommended to go down until 40 micrograms to have a higher sensibility and less diagnosis errors. The difficulties in urine collection, you know how difficult this is, especially with the pediatric populations to collect urine. So this is a supplementary difficulty. Hepatic or liver copper, Marina explained all the errors if we just overtrust this level, and it's very difficult with children, especially. Only with regard to the biopsy, the main problem that we have is that if we want to do the dosage, specifically we need to do this sample for the copper. We did a biopsy for another reason. It was sent to the histologist, to the pathologist. They don't keep the sample, and this dosage result is incorrect, and that's one of the problems that we find. We might find elevated levels, and this could be another condition, and that can induce us to error. And also, sometimes we have normal values, as we've seen. Marina explained some elevated cases that finally were not diagnosed as Wilson, but with urine, with children, it can be quite the opposite. We did this as children with biopsies. We found not so high levels, and yes, right, they were very small children, so we were expecting that this hepatic copper was not so high. I think Marina explained very well what the relative exchangeable copper is. I need to talk about this, because it's very, very useful, a very useful test. So it seems paradoxical. It's an accumulation of copper, this Wilson's disease, but then we find that it's quite low. It seems pretty strange. The problem is in this taxi, so to speak, this ceruloplasmin. People know Wilson's disease. Most of the copper is bound to that and is different in Wilson's disease. There is a free part and then another part bound to proteins, and this is what we call exchanged copper, REC. And when we do this ratio, but basically we found I don't know, 18 for Parisians or 15, so between 15 and 18. But this is very useful, and Marina showed this publication. This is great, the ERC, 100% sensitivity and specificity and diagnostic. And I think in France we've sometimes committed the mistake of trusting this 100%. We're waiting for the REC, and then we go like, all right, this is a Wilson's patient or no. But basically we've seen in children's population that this is not 100% to be trusted. And we've seen studied the cohort of patients, and out of 41 children, we saw that only 36 had an elevated copper, and 6 of them had this REC was lower of these 15 to 18% values that we gave, and it stood between 12 and 14. But when we see high values. The lab might tell us, okay, it's less than 8. So when we go, like, we get values like 10, 11, 12, we repeat the study. But these values were pretty low. 11 is pretty high, as many of them had 4%. And the first patient, and not only once, but in repeated tests. This test is not easy. I'm not a biochemist, but I've been told that you need certain expertise to be able to perform this in the lab, and our lab is quite experienced. And the first patient of this cohort basically was from Luxembourg, and they lived close to Lyon, and they came to visit. The hepatic enzyme was high, the ceruloplasmin was borderline. We did the RAC, okay, go home, you're not Wilson's. We did all the tests, and then basically when we did the gene test, the patient had all the most common mutations. We thought that that was a mistake, but we found that there were many children in the same situation that were diagnosed in the time where we didn't trust the REC so much. Basically, there is not a specific test for Wilson that is going to work all the time. These children, basically, there is a publication to try and understand what's going on with these children, the test, the exceptionality of these children. We didn't find anything special. The only thing here with these 6 children, 4 are siblings. Maybe there is some genetical trait in this family, something in the background. But basically they have these classic mutations, and one of them have the most frequent mutation outside of Spain, in Europe. But anyway, this helped us to avoid this 100% trust on this RAC. But we can say that there's no problem if we have this RAC, increased RAC. We tend to find, we haven't found any false positives, but we've unfortunately found some false negatives. So we were not very happy to publish. So it was only France, the only one publishing, but luckily Spain and France, and I think Denmark as well, are publishing. But still, there's a need to perform further sort of studies, and I expect that in the Leipzig score, the REC. Okay, for treatment, I'm talking about children because they were our cohort, and we didn't find any that gave us a problem with this type of test. In terms of the treatment, okay, diet is included here. So there is this survey at a European level about what are the customs here. I don't know whether Spain follows the same as France, but what we can conclude from this survey that is about to be published. So there is a high variability among countries. We need to do, I don't know, this specific strict diet or not. But in children, I see that in Spain they use the same, I don't know, sort of list as us, when we tell, well, chocolate is the main problem. If we tell them you don't have to eat foie gras or something, that's no problem. But when we ban chocolate, that's a problem. I don't have a unique sort of answer. That's what we do. We need, well, I'm not sure if you can see these clearly. Well, the Nutella, basically, it's in yellow. It's not so forbidden, so to speak, but ideally, black chocolate we should be avoided. It's banned during the first year of diagnosis, but later on, if the condition is well controlled, there is not a specific contraindication. So if the condition, as I say, it's well controlled, we do not ban chocolate in children, and I hope that's the same situation in Spain. Then, well, In terms of drugs, the main problems is that there's no dosage form for children. Basically, we have these pills, we have these many pills that had to be taken every day, daily intakes. Sometimes because of this weight problem, we need 1.5 pills and they need to be cut. They told us that there is this sour taste of the cerealamine and they are not able to ingest it, and they cut it in small bits, they mix it with something like that, and we have to increase the dosage because that doesn't work probably well. Some I don't know, some labs are going to change this dosage forms, sachets or any other types of presentations. Side effects are rare, and every dosage form involves an investment. Basically, that's a problem with this dosage form. Another issue, and not just for children, is the number of daily intakes. 2-3 times in some cases, and that's a problem, not for children, but it can be especially for those who eat in the school canteen. There is not a unique solution for that. This hasn't been described. We sometimes tell patients to do one single intake, but basically this number of daily intakes is a problem. And instead of the recommendations of the drug, basically the package insert tells us that we have to take it after or before the meals, 2 hours before, 2 hours later, and then after different meals, and that's basically a challenge to comply with that. Well, this is the official recommendation, but for children with problems to remember or who have nausea, we recommend them to increase the dosage for various reasons, but that's a problem with children in general. And as for side effects, we don't have more side effects in children, but we need to acknowledge that the DPA with skin problems and so forth, the children will be treated for the rest of their lives. And there is a higher risk that with time they can develop these side effects with the treatment. And I think that's a specific problem for children as well. And again, following with the last part of my presentation, I think the main issue, and I think Luis explained that, it's the awareness of the condition. And when we move to the teenage years, sometimes we've diagnosed for an anecdotal sort of situation, and sometimes this poses a shock. When we have early diagnosis, we avoid many complications, but the main problem is that they do not have this awareness that they have a condition. They're not feeling anything, but maybe they have to undergo more blood tests, but they don't feel that they are sick. And this treatment with fasting conditions can give them some nausea, and with the teenage years they feel better, and they stop the treatment because they don't feel this nausea, and they feel that the condition has disappeared. And I think that's the situation everywhere. The main problem of the teenage years, they feel better and they abandon the treatment, and then we have more symptoms, further symptoms coming up, and then it's more difficult to recover lost time. And the therapeutic adherence is not specific from children. I think the children are the best compliers because you have the parents supporting them. But once you get independence, teenage years, young adulthood, this poses a large problem because we don't have any symptomatology. And well, adolescence poses a problem, doesn't it? with adherence, with all the related problems, I don't know, being able to do absolutely everything, this idea that you don't need anything, feeling so powerful. And we have so many patients that abandon the treatment for 5-6 years until they start to feel some tremor, and unfortunately we cannot recover those lost years. We also have the issues of alcohol and substance abuse, and I'm a pediatrician and I consult with the adult hepatologist, and when we do this switch, they ask their questions when we do this referral of the patient. And alcohol is like, okay, children do not take alcohol, but when the patient is 18, the adult hepatologist might be a little more flexible and authorizes maybe some alcohol during the weekend. And that's basically, they opened the gates. Okay, how much is a little bit? So then we have this problem of this patient. It's not the treatment, it's rather the alcohol consumption. And so be very careful with these, within these switch processes. What are we telling the patients? In Lyon, we started with the pediatric patients, and now we had young adult patients coming to our department. So this switch is naturally done in the same site, but I think we are unique in this case, and but we really need to be aware of this shock when we change from one age period to the next. What I can see in Lyon is that I don't know, the patients come to see us. This is a very challenging period, and we need to be aware of that. And we start the problems with the contraception, and depending on the state of the liver, we have to determine what's a contraceptive method we can use. So we need to approach all these issues. And anyway, to summarize, Marina explained that it's very complex to diagnose Wilson's disease. We have many borderline cases, and genetics helped them, and the exchange copper as well. Basically, we have different complexities that we need to take into account, and REC also can be, if that's the only measure, we have to be careful with that. And anyway, that's a summary of the main issues that I can see with children and adolescents.